right? So what you do is there are going to be two waves between QRS complex and a normal ECG. There should be two waves between QRS complex. The wave that is closest to the previous, the first QRS complex, will be the T wave. The wave that is closest to the second QRS complex will be the P wave. That's how you're gonna know, right? In case you have you're giving an ECG where there's no P wave, for instance, and I see maybe it's actually they only have T wave between the KRS complex. If the T wave is closer, if the distance between the T wave and the first KRS complex is shorter than the distance between the wave and the next KRS complex, is going to be T wave. Or maybe a patient has a condition where there's no T wave and there's only one wave between between two KRS complexes. If the distance between the wave and the initial KRS complex is longer than the distance between the wave and the next KRS complex, is going to be definitely the P wave. Yeah, so P wave will be closer to the second KRS complex or the next one, the one after it, than the one before. While T wave will be closest or closer to the KRS complex before it and the one after it, right? Okay, so what produces P wave? ECG usually starts around here. Because so SNL will fire somewhere here. You can't see that on ECG, and then atrial becomes depolarized. So P wave represents what? Atrial depolarization. Then there will be a pause, right? Once the atrial depolarized, there will be a pause at the AV node. AV node is the slowest conducting, right, fiber in the conducting tissue in the heart. So AV node will slow down the action potential and create what? This PR interval. But you can see that the PR interval actually includes what? Includes the P wave and the pause or PR segment. So, and then once the wave makes it past the AV node, enters the Purkinje system and the E's, and it's going to simultaneously depolarize, right, the ventricles, and that leads to what? The QRS complex. And you can see the QRS complex normally is narrow. So my PR interval should be within like one big box, right? So ECG, it has like 5 small boxes will form one big box, right? And on the ECG strip, a small box is 0.04 second. One small box is about 0.04 second. So a big box which contains 5 small boxes will be 0.04 times 5, which will be 0.2 second or 200 millisecond, right? So a PR interval, that is the distance between from the beginning of the P wave to the beginning of the KRS complex, must not be more than one big box. It should be within one big box, within one big box, or less. KRS complex, they typically within 3 small boxes. The duration of the KRS complex, that's from the beginning of Q wave to the end of the S here. That's what we can say how narrow KRS complex is, because it's a good thing because both ventricles are going to be depolarized simultaneously. So the width of the KRS complex will be within, right, within 3 small boxes, right? That's about 0.12 seconds or 120 milliseconds. 3 small boxes or less KRS complex duration. Then you have after the ventricles depolarize, producing the QRS. And remember, so Q, if you want to separate the waves even better, Q represents the septal depolarization. The septum depolarizes first, the interventricular septum. R represents the body of the ventricle depolarization, and then S usually represents the base, but all of them together represent ventricular depolarization. Then T is ventricular repolarization, right? T will be ventricular repolarization, and there's also going to be like a segment. There will be a pause between the end of the KRS depolarization and the beginning of ventricular repolarization, right? We call that the ST segment. And then we have the T wave, which represents ventricular repolarization. And right, so the cycle stops here, and then SN will fire again, and then you send that P wave, and the cycle continues. So the distance between the beginning of the QRS complex to the end of the T wave, right? That's what called QT interval. QT interval. And as you can see, the QT interval involves what? Involves QRS complex, involves the ST segment, involves the what? The T wave, includes the T wave. QT interval is about approximately 2 big boxes. The total length of the QT interval normally should be within 2 big boxes, right, or less. So if it's longer than that, then there's a problem. We call that prolonged QT, right? Yeah. So we know what the P wave is. We know the PR interval represents by the pulse or PR segment, the pulse at the AB node. The PR interval should be totally 1 big box or less. The QRS complex, you know what it means. Total normal duration should be about 3 small boxes. And then we have the ST segment, then we have the T wave. T wave represents repolarization. And the QT interval, which includes QRS complex, ST segment, T wave should be what, about 2 big boxes. So that's the normal. Let's add more details. Beginning of the QRS complex. Yes, yes. This is the beginning of P. This will be the beginning of QRS complex. That's your PR interval. Yes, yes. Okay. So, um, for KRS complex, right, this is linked towards fast sodium channels. So the channel that will mediate ventricular depolarization will be the fast voltage-gated sodium channels on the myocyte. So, and that's important. You can link that channel to KRS complex. Then the channel will link to the ST segment is going to be the calcium channel. So calcium channels on myocytes are linked to ST segment. They're the ones running for the plate 2 phase, right? Phase 2 of ventricular action potential. And then T wave will be linked to potassium channels, which is phase 3 and 4. T wave will be linked to potassium channels, which will be phase 3 and 4 of the ventricular myocyte action potential. Yeah. So KRS complex fast sodium channel, that's phase 0. ST represent the plate 2, that will be phase 2, which is calcium channels, and T represents the phase 3 4, which is potassium channels. 0, it's on the 1, 1, 1, 1, let me see. 0, 1, 2, 3, 4, 0. Okay, that will be 1, phase 1, upstroke, right? Yeah, sodium channels, phase 1, and then phase 3 will be, yeah, ST segment, calcium. Phase 4 will be potassium channel, T wave. Yeah. Yeah. So it gives me an idea of what changes I would expect to see, right, on ECG if something is wrong with those channels. For instance, if a patient is taking a class 1 antiarrhythmic, blocks sodium channels, blocks phase 1, then they're going to have wide KRS complex on ECG. Or patients with TCA toxicity. TCA is they block sodium channels on the myocyte as well. They block phase 1. So you're going to see wide KRS complex in those patients. If a patient has a patient is on class 1A and class 3. Class 1A and class 3 antiarrhythmics block potassium channels. So that will affect the onset of repolarization. So T wave will be delayed, which means my ST segment will be wider. The the QT interval will be wider as well. So the distance from the beginning of the KRS complex to the end of T wave will be increased because there will be delayed repolarization if we block phase 4, which is potassium channels. Yeah. So those patients will have prolonged QT interval. Prolonged QT interval, right? Which can lead to like SADs. And so that's on ECG. So back and forth, right? Examiner can give you the channel or the drug, ask you about the change you're going to see on ECG. I'll give you the change on ECG, ask you about which channel, right, is likely affected. And pathologies that affect calcium on phase 3, the plate 2 phase, can also prolong the ST segment, and that will also contribute to prolonged QT interval as well. Yeah. Then we know PR interval represents AV node conduction. So if the PR interval is prolonged, then you're dealing with what? AV node inhibition. Something is blocking the AV node. So that's why we have like our heart blocks, medications like beta blockers, calcium channel blockers, they can prolong the PR interval. And if the PR interval is also short, that's also a concern. Sometimes patient will not even have that PR segment will be missing, right? So you're gonna see an ECG where the P, after P wave, we're just gonna see KRS complex. Immediately after that, there will be no pause between the P and the KRS complex. That is where patient has a very, very short PR interval or PR segment, or they have no PR segment whatsoever. Yeah. So shortly after P wave, they will just transition into KRS complex. You won't see that AV node conduction. That pause will be missing. So that tells you the patient has an accessory pathway. They are getting current from the atria to the ventricles through another pathway and bypassing the AV node. Yeah, that's something you're going to see in Wolff Parkinson White, right? Syndrome. So in those patients, the ECG looks something like this, right? So P, then you can see the KRS complex follows immediately. After that, there's no pause whatsoever. So we call that like pre-excitation, right? That patient has like an accessory pathway bypassing the AV node, like a bundle of Kent in Wolff Parkinson White syndrome. Okay, so for basic, we should know those. Okay, now next thing we should know at this level will be for step 1. That's also going to be super important. Maybe for step 2 as well. Is going to be the leads, right? Location, which part of the heart do the leads represent or correspond to? Which locations, which wall of the heart do the leads correspond to? And this is going to allow you to determine which coronary artery is likely affected. If somebody has like MI, as well as determine where the infarction is, right? So let me see here. Okay, so three major like surfaces, I think, yeah, for the heart that we should know. Maybe four. Definitely inferior wall, We should know the leads for the inferior wall of the heart, and then we're going to talk about the corresponding artery. So first will be the inferior wall of the heart, the base, not the base, rather, the inferior surface, the diaphragmatic surface, the surface resting on the diaphragm, inferior surface. Then we have the anterior surface, so inferior, anterior surface, and then there's the lateral surface, and then posterior surface. So inferior, anterior, lateral, posterior. Put inferior and posterior close together in your notes. Put inferior and posterior wall, put them close together, let them follow each other because they are like linked by the same artery. Then put anterior and lateral close together, because you're gonna see sometimes they're gonna give you a question where patient has like anterolateral MI, because the anterior and the lateral surface are actually supplied by the same coronary artery. Then the posterior and inferior wall are supplied by the same coronary artery, which means they can occur together. Yeah, depending on where the infarction is or the occlusion is. Alright, so under the artery column or blood supply column, for inferior and posterior wall, they are supplied by what? Right coronary artery. For the inferior and posterior wall, they are supplied by right coronary artery. If I want to be more specific, they are supplied by the posterior descending artery, which is a branch of the right coronary artery. So the posterior and inferior wall are supplied by PDA, which is a branch of RCA. In addition to supplying those parts of the heart, the RCA and the RCA also supplies what? The AV node, the SA node, and the right ventricle. In addition to supplying the inferior and posterior wall of the heart through the PDA, RCA also has additional branches like the nodal branches to the SA node, to the AV node, and it supplies the right ventricle, the most of the part of the right ventricle, most part of the right ventricle through the right marginal artery. So that information gives me an idea of what can go wrong if somebody has right coronary artery infarction, especially if it's very, very proximal infarction. If there's an infarction or occlusion of the RCA, very, very proximal, close to the point of origin, patient can have what? SA node dysfunction, bradycardia. They can have AV node dysfunction, heart block. They can have right ventricular infarction, right ventricular MI, or failure of the right ventricle, and they can also present with what? Infarction of the inferior posterior wall, which will affect the left ventricle as well, left ventricular failure if the inferior wall of the left ventricle is not working well, as well as the posterior wall, as well as the interventricular septum, right, which is also supplied by the PDA, the posterior 1/3. Yeah, so those areas will be affected by RCA occlusion if it's very proximal. But the distal, if it's more distal, it may affect just maybe the inferior wall alone. It may affect only the posterior wall and the inferior wall, things like that. So because we don't have, right, because we don't have a lead, so where the conventional lead, the conventional 12 lead EKG, right, if you know, it doesn't have, or it doesn't it's not, we don't have lead on the right side of the chest. A conventional 12 lead ECG, right, we don't place the lead on the right side of the chest, so we cannot look at the right ventricle directly with a conventional lead unless you do the right sided, right, chest leads. You have VR on the right side, right sided V4, V5, V6, and stuff. However, we don't, for the conventional leads, they are all on the left side of the chest, right, so not on the right side. So we don't have we are not looking at the right ventricle directly with the conventional ECG leads, and you cannot look at the posterior wall directly as well with the conventional lead ECG. So what we look for to kind of predict, what you're going to look for on ECG to predict if a patient actually has a posterior MI or they have a right ventricular MI is to look at the inferior leads. Since the inferior wall is also supplied by the same artery that supplies the posterior wall, supplies the right ventricle. So if there's an occlusion that is proximal, there's an occlusion of the proximal RCA, it's going to affect all those walls, including the inferior wall, which is the most distal of all of them. Yeah. So if by looking at inferior wall ECG, I can predict or speculate, right, if a patient also has a posterior infarction or they have a right ventricular infarction as well, because all those structures are supplied by the same artery. Yeah. So that's how we diagnose posterior wall MI, by looking at inferior leads. If there's inferior infarction, we diagnose right ventricular MI as well by looking at inferior leads. Yeah. But if you want to confirm, you can now do a right-sided ECG to confirm right ventricular MI. If you want to confirm posterior MI, you can do a posterior ECG. Yeah, the V7, V8, V9 and stuff posteriorly. But conventional ECG, we don't do them, so you can use inferior infarction, right, to predict if they are affected. So which leads represent inferior wall? 2, 3 AVF. And AVF is easy to remember because remember AVF is it's AVF represents foot, F foot for foot, right? So usually the left foot. So I mean left foot is inferior. The lead is going to be placed on the foot, which is inferiorly located. So it's going to look at the inferior part of the heart. Also leads 2 and 3, they are located kind of inferiorly on the chest wall, so on the abdominal, on the extremities. Yeah, inferior part of the extremities, lower extremities. So they also represent right inferior wall of the heart. So 2, 3 AVF inferior wall. So which we can use to predict, indirectly predict posterior wall and right ventricular MI as well, because they are all supplied by the same coronary artery. Now, anterior wall, anterior wall, which is mostly the anterior part of the left ventricle, the anterior 1/3 of the interventricular septum, and just a few area or limited area of the anterior right ventricle as well. So anterior wall will be supplied by V1, V2, right? V1, V2, V3, V4. Anterior septal wall, V1, V2, V3, V4. Leads, chest leads, V1 to V4. Then the lateral wall will be V5, V6, lead 1 and AVL. Lateral wall of the left ventricle, V5, V6, 1 and AVL. AVL for left, so the leads on the left hand. So we represent the lateral wall. Yeah, V5 and V6, they are chest wall. They go all the way to the axillary fossa, right, or axillary region, the side of the chest. So also lateral leads. So inferior wall 2, 3 AVF, anterior wall V1 anterior septal of anterior V1 to V4. Then we have the lateral wall of the left ventricle V5, V6, 1 and AVL. AVR is a misnomer, like it's on the right side, so it doesn't represent, on the right hand. It doesn't represent like any surface directly. Yeah, so don't worry about AVR at all. It doesn't represent any particular, it has no group. It's just one isolated lead. But we need at least 2 contiguous leads to represent a particular surface right of the heart. So AVR is just isolated, so we can't use it to really interpret anything. It's not reliable. Or the other ones that are reliable for specific areas of the heart. Yeah. So artery, what do you know? Inferior artery, right? RCA. So which means 2, 3 AVF represent RCA, specifically PDA. The anterior leads represent left descending artery, left anterior descending, LAD. The anterior leads V1 to V4, they are supplied by, or the anterior wall of they are supplied by LAD. So anterior leads represent LAD distribution, left anterior descending, which is a branch of left coronary artery. The lateral leads represent left circumflex artery distribution. The lateral leads represent left circumflex artery distribution, which is supplied by left coronary artery as well. So an examiner can give you the leads where the pathology is and ask you which artery is occluded, right? Or they're gonna give you the artery and ask you which leads will have the ST elevation or depression or right evidence of infarction. Yeah. So know the arteries, know the leads, and the surface of the heart that corresponds to. You may also get question about, and so remember the transition, right? How we've been moving. So we start from RCA. RCA comes from the right coronary sinus, right? Sorry, right coronary sinus or aortic sinus. So RCA can give rise to right marginal, goes to the right ventricle, then becomes the PDA, which is the terminal branch, and PDA will supply the posterior wall and the inferior wall. Left coronary artery starts from the left aortic sinus or left coronary sinus, and then it's going to give rise to LAD, which is supplied the anterior wall, and then give rise to left circumflex, supply the lateral wall of the left ventricle. Yeah. So most people, right, in the population, I think about 75% or 80%, they are what? They are right coronary. The right coronary artery is the dominant coronary artery, while in about 20% of people in the population, left coronary artery is the dominant coronary artery. What do we mean by that? The coronary artery that gives rise to PDA is the dominant artery. The coronary artery that gives rise to posterior descending artery is the dominant coronary artery. So in most people, PDA will come from right coronary artery. In a few group, PDA comes from left coronary artery. Unless stated otherwise by the examiner, assume whatever question you're giving, it is right dominant circulation. Only if the examiner wants you to, if the examiner is giving you left dominant circulation, the examiner will mention that. Otherwise, always assume, right? It is right dominant and use that to make a decision or pick an answer. Yeah. But if it's left dominant, then it's gonna be left coronary artery. So left coronary artery will give rise to left circumflex, and then left circumflex will continue posteriorly as what? Posterior descending artery. Yeah. And then it's to supply the posterior wall and the inferior wall. Yeah. If the patient has left dominant circulation. Okay. So all right. Let's look at some examples of ECG, right, for MI. And so this is just looking at changes that you're gonna see, right, on ECGs in patients post infarction. I mean the earliest change for and the earliest ECG change will be the hyperacute T wave, right? We have all this very tall T wave. Hyperacute T wave is gonna be the first ECG change that we usually see on in patient post MI. Hyperacute T wave, very tall T waves, and but this is not. There are other conditions that can cause this, right? So you can see this hyperkalemia as well. So be careful in that kind of thing here to make sure the patient actually has the signs and symptoms correspond, right, to infarction, and it's not a patient with hyperkalemia, right, that we're dealing with. And ST elevation we've seen in STEMI, and ST elevation suggests what? Suggests transmural myocardial ischemia or injury, right? There's the injury to the myocardium will involve the full thickness of the myocardium. That's what ST elevation represents. ST elevation suggests transmural full thickness myocardial injury, because in STEMI there's what complete occlusion, right? 100% occlusion of the coronary arteries. In STEMI, there's 100% occlusion of the coronary arteries, so the whole wall of the myocardium will be impacted or injured, ischemic, against the STEMI. ST depression, however, suggests what? Subendocardial, represents subendocardial myocardial injury. Only the deepest layer of the myocardium is injured. Remember, the blood supply to the myocardium will go from superficial to deep, right? So the coronary arteries, they run close to the surface, the pericardium, and then they're going to send these deep penetrating boundaries, right, to the muscles. Yeah. So in end STEMI and unstable angina, right, we have less than 100% occlusion from the pathogenesis, right? If you guys remember, of pathogenesis of coronary artery disease, in end STEMI and unstable angina, the coronary artery is less than 100% occluded. Yeah, it's not completely occluded. So there will be decreased blood flow to the myocardium, but not complete loss of perfusion, just decreased perfusion. So the deepest, the area of the myocardium farthest away from the blood supply will be injured. The area of the myocardium farthest away from the blood supply will be injured in that case. So, which is the subendocardia, right? The part of the myocardium close to the endocardium. So that we're going to see subendocardial infarction, subendocardial injury, and that will show up on ECG as ST depression, right? ST depression. But ST elevation is the ECG manifestation of full thickness transmural infarction, where there's because of 100% occlusion of the coronary artery. So there's no blood flow at all. The full thickness of the myocardium will be injured, and we see that we call that STEMI. Yeah. So this is what. So if I see either STEMI or end STEMI or hyperacute wave in more than two contiguous leads that represent a particular surface of the heart, you have your diagnosis. Patient has MI or end-stem or ACS. Whether you say end-STEMI or STEMI or end-STEMI, patient has acute coronary syndrome, and then you can determine which coronary artery, right, correspond to that lead, and yes, that tells you where the lesion is in that patient. Q wave is something you might see in hold infarction, right? Hold infarct, where the Q wave is very, very deep, deeper than normal. Alright, let's see some ECG example for MI. So look at this ECG and remember, right? First of all, I've told you guys this principle before. If I have a vignette that has ECG, what do I read first? I'm not reading the ECG first, right? You don't ever make that mistake of going to the ECG. Bad strategy. Your first goal is to read the vignette first. Read the physical exam fine, depending on what the structure of the question. If it says most likely diagnosis, go from the top, work your way down, and see what's going on. If the question is another type of question, you're going backwards. But you're going to see there will be clues in the vignette to tell me about what kind of cardiac pathology I'm dealing with in the first place. Because that's important. Right? Is it tamponade? Does the clinical vignette look like tamponade? So if it's tamponade, I know what I should be looking for an ECG, right? If I eventually, even if I need to read ECG at all, if the clinical vignette looks like in fact ACS, right, crushing chest pain reaching to the jaw, to the upper hand, right, things like that, then I know what I'm looking for on ECG. What to be looking for on ECG in that case. If the clinical vignette looks like pericarditis, acute sharp chest pain, worse when the patient lies down, right? Gets better when they lean forward, right? Pericarditis, then you know, okay, if we, in that case, I can go and pick my answer. Or if you need to read ECG, you know exactly what you are looking for pericarditis, and you just go straight to that and confirm and move on.
So I don't have to read every segment of the ECG because there's no time for that. If a patient is having like so somebody with heart failure, right? They're telling you the apical impulse is displaced. They have congestion. Patient has diffuse hyperdynamic impulse. You're thinking hypertrophy. You hear S3, S4, thinking hypertrophy or dilation of the heart. Then you should know what to be looking for. I'm going to talk about that as well. Right? Tall R waves. All the R waves or chaos will be very, very tall. It's going to be taller than normal because we now have thicker muscles, right? So the voltage, the height of the carriage converter will be top. So you're just going to look for that thing to confirm it and you move on. You're not looking for MI features, you're not looking for ST segment elevation. No. Right. So patient has palpitations, right? Heart is racing. Then you know you're dealing with tachyarrhythmias. Then your strategy will be different. Different approach to reading the ECG in that case to confirm. Oh, patient has slow heart rate. Suspect is brady arrhythmias. Yeah, brady arrhythmia. Your strategy will be different. I'm not going to be looking for ST segments. I'm not going to be looking for contiguous leads or to, I don't care. Different strategies and arrhythmia now. So that's why you're not reading ECG first. You're reading the vignette first to determine what type of pathology the patient has, and then you're using the ECG to confirm that pathology, not to diagnose it, not as the first right step, but as a supplementary right resource. So never read ECG first, read the BS first, determine what type of disease the patient has. Once you determine that, you ask yourself, what do I expect to see on ECG in this condition? Then you go and confirm that with, even if you need to, go and confirm. If you don't, do not confirm anything, go and pick your answer, move on. Yeah. All right. So let's say we have a clinical vignette that looks like infarction. So okay, patient comes in, I mean, other patient, there's all these risk factors for atherosclerosis, there's crushing chest pain, relating to the jaw, to the arm. Yeah, you think, okay, this is ACS, right? Okay, you know what you're looking for in ECG. I'm looking for hyperacute wave. I'm looking for ST segment elevation. I'm looking for ST segment depression, blah, blah, blah. You just go straight to your ECG. So you're going to read each lead to see, because you want to know the location and you don't want to localize the surface. Where is the infarction? So I'm going to read each lead quickly, look at the ST segment and the T wave to quickly see if there's deviation or not. So starting with lead 1 here, at the top here, I'm going to read that first and see, yeah, so lead 1, I remember the depression or elevation has to be very, very prominent. It's going to be like more than about 2 millimeters, right? More than 2 small boxes. Right, in most cases. So it has to be very, very prominent, super prominent. So if it's not prominent, it's probably nothing huge, an artifact, you move on. So that's to be clear cut, very, very prominent. So look at one here, there's maybe slight depression here, and you're comparing the ST segment with the PR, right? PR segment. So there's a slight depression here, but it's not, it's about one small box. I don't really care, probably just an artifact. Don't worry about AVR. We don't care about AVR. Suspecting MI, skip that. And then look at one here. There is, right, some elevation in V1, but in V2 too as well. There is some elevation in V2. Yeah, V3 looks okay. V6 they look fine. But then I go down, I see lead 2 here. You can see definitely prominent elevation here, prominent elevation here, and I go down to 3, very, very prominent elevation here, and look at AVF, super prominent elevation here in this patient. Yeah, so this patient has definitely has a STEMI, right? ST segment elevation, MI, and there are 3 leads here that are involved that represent what, one surface of the heart, which is the 2, 3, and AVF. And this represents what surface of the heart? Ross. Inferior wall. So it may likely has an inferior wall, MI, STEMI. And which artery is likely occluded? Right coronary artery, specifically which branch of right coronary artery? PDA, right? Posterior descending artery. Yes, posterior descending artery. And if the examiner wants to go a little bit further, they can ask about the pathogenesis. They're going to say, okay, what lesion will you find in the maybe right coronary artery or the occluded coronary artery in this patient or involved artery in this patient? We're going to see complete, right, occlusion. There will be ruptured plaque, antematous plaque with platelet thrombus leading to 100% occlusion because this is STEMI, so it's a transmural infarction. So that'll be 100% occlusion, yeah, of the artery. Okay, so you see that you've done. Let me see, there's going to be, let's see the next one. So this one too, same clinical picture. A patient comes in, they have been right, this crushing chest pain related to the jaws, the upper arm. You suspect, okay, this is some sort of ACS going on. Right, I go to my ECG, I know what I'm looking for. I should be looking for evidence of right STEMI or end STEMI or T wave abnormalities. So still starting, you can quickly read all the leads and just look at the ST segment and see where is the problem. So if you look at this one, so starting from the top here, this one is not that clear, but we can still make it work. So we have lead 1 at the top here, and yeah, it's not this okay. Nothing's wrong with lead 1. That's out. Lead, if you go across to V1, okay, nothing here. That's okay. If I go down to V2, okay, this segment looks elevated for sure for V2. For V3, there is elevation as well. Look at where the segment starts here for V2. So it is above the PR segment, prominently above. V5, same. V4, same thing. V6, same thing. Right. And then let me see. Look at the 2 here. 2 is okay. 1 is okay. 3 is okay. And I think this will be AVF is also okay, right? So where the problem is so far is what is the V's, V2, V3, V4 as ST elevation, and then yeah, S elevation in V2, V3, V4. Let's go down to V5. Oh yeah, V5 and V6 as well. So all the most of the V's 2, 3, 4, 5, and even 6. V6 is ST segment elevation. So this patient definitely has STEMI as well. And it's what? Anterolateral wall. Remember V2, V3, V4, they represent anteroceptor. V5, this is represent lateral wall, right? So this is anterolateral infarction. Which coronary artery is likely occluded here? Conduction. Left coronary. Good. Left coronary. Since we see anterolateral, which means both branches of the left coronary artery are involved, both the LAD and the left circumflex. It has to be the coronary artery itself. That is what occluded. Yeah. And since this is STEMI, Shani, what lesion will we see in the left coronary artery? What kind of lesion will we see on pathology? We're going to say complete occlusion of the coronary artery, good, and transmural infarction of the what of the muscle, right, in this location. Okay, very good. So that is that. Next one, this one is going to be okay. So this is a patient that comes in, right? So this patient presentation is different. Patient came in with chest pain, and the examiner did not tell you, right? Examiner didn't tell you that the chest pain is the examiner did not tell you what type of chest pain, whether it's sharp or crushing or whatever. And we're thinking, okay, it could be MI. Other differentials could be pericarditis as well. And here's the thing. So pericarditis ECG, right, can look like MI. They have something in common. What they have in common is that they both cause ST elevation. How do you tell them apart? First, the ST elevation in MI is confined to a few contiguous leads that represent the same surface of the heart. The ST elevation in pericarditis is diffuse. It's going to involve all the leads, whether contiguous or not. Leads that represent different surfaces of the heart will be affected. Against ST elevation in leads that represent different surfaces of the heart, leads that are not supplied by the same coronary artery. So, and it's gonna be super rare, right, for somebody to have diffuse occlusion of all the coronary artery at the same time. Yeah. So if I'm seeing ST elevation that involves multiple leads representing different coronary arteries, different sections of the heart, likely pericarditis, not MI. MI will be confined to a particular surface of the heart, confined to a particular arterial distribution. Yeah, that's where the ST elevation will be. So that's the first thing you're looking for: diffuse versus localized, confined. Then, second thing you can use is what? So remember what I told you about ABR. ABR is typically useless to us in MI, right? But it's going to be useful to us in what? In pericarditis. If I see, right, if you're looking at an ECG, if you see, of course, ST segment elevation in some leads, and you're going to see ST segment depression usually in AVR, but in pericarditis, right, only AVR and V1, only AVR and V1 should have ST depression. In pericarditis, only AVR and V1 will have ST depression. Every other lead will either be normal or they're going to have ST elevation in pericarditis. But in MI, you're going to see other leads besides AVR and V1 with ST depression. There will be other leads besides AVR and V1 with ST depression, right, in MI. But if it's pericarditis, only AVR and V1 will have ST depression. There will be no other lead with ST depression. The other be elevated or normal. So let's look at this ECG. Let's apply the first rule. Let's look at the ST elevations and see how many leads are involved or have ST elevation first. Let's see if they are contiguous or it's diffuse. It's non-specific and random. So let's start from the top here. So look at this one. This is, I know it has to be prominent, right? It has to be very, very prominent, visible. So this is my PR interval here at this level. My PR segments will start from this level here for lead 1. And if I draw a line across that, you can see that, okay, there's no ST elevation or depression here for 1. So that is out. 2 looks okay. That's okay. Yeah, but there's something wrong here though. There's PR depression here. So the PR segment, right, it looks depressed, not actually elevated. So although we don't have ST elevation, but we do have, right, PR depression. And see this point is depressed. It's below the line. The KRS complex starts at a lower level, right, than they should. Yeah. So PR depression is something you might see in pericarditis. So 1 and 2, they don't have ST elevation, but there's PR depression. That means I won't see that in MI. So that may suggest pericarditis. So that's one thing there. We're gonna leave that. And then look at 3. 3, there's no depression elevation, so that's normal. Here it's not that prominent. It's still, I think, normal for V1. That's okay. For 2, there's no ST elevation, but we can also see PR depression right here. So still suggesting, right, or supports pericarditis. And then if you go down further for 2, actually there's ST elevation here. Elevation, 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 right? Yeah. So 2 has ST elevation. And then let's go to AVR. AVR, we're going to come back to AVR when we look at depression. So AVL has elevation as well. So AVL has elevation, 2 has elevation. Then look at AVF. AVS also has elevation here. A little bit, yeah, it does. So AVF is elevated, AVL is elevated, 2 is elevated with PR depression in 1 and 2. Okay, and then look at V1. We're going to come back to V1 and ABR when we look at the depression. But look at V2, elevated, V3, elevated, V6, elevated, V5, elevated, V4, elevated. So, elevated, 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 elevated. Are these leads? So how many leads? 2, AVL, AVF, V2, V3, V4, V5, V6. Do all these leads represent the same coronary artery distribution? No, this is diffuse ST elevation because AVF is what? Inferior wall. AVL, V5, V6 lateral wall, V2, V3, V4 they are anterior wall, right? Yeah. So AVF is completely even, is the odd one out there. Because let's say the anterolateral can represent LCA, but the fact that AVF is high, that is inferior wall, it has nothing to do, right, with LCA. It is the right coronary artery. So there is multiple leads here that are not, that do not represent the same coronary artery. Yeah. So this is diffuse ST elevation. Let's say you still okay, doubting Thomas, right? You'll be like, okay, let me confirm further. Let's look at the PR depression now. Let's look at the ST depression. We expect to see ST depression where in only AVR, which we have here, right? And V1 in pericarditis. And here you can see V1 too has depression. Is there any other lead here with ST depression besides AVR and V1? Any other lead with ST depression besides AVR and AV and V1? And the answer is no. So this is definitely what? Pericarditis. Akis pericarditis, not MI. If it's an MI, you're gonna see ST elevation confined to certain leads only, but and you're gonna see other leads with ST depression as well, besides AVR and V1. So this is how you tell them apart on ECG. If the presentation is not clear, yeah. Diffuse versus localized, ST elevation, and then uh, ST depression confined to only AVR V1 pericarditis, ST depression that involves other leads besides AVR V1 MI. Any question on this? Okay, all right. Let me before we look at arrhythmias, let me talk about some other ECG findings for some conditions. First, I don't actually have examples here, but I'm gonna just draw something out a little bit. For if, heart failure, right? Yeah, how do we confirm hypertrophy, ventricular hypertrophy rather, on ECG? You're looking at what? V1, your focus will be V1 and I think V5 or V6. So you're gonna take the S wave in V1 and you had it right, the S wave in V1 in millimeter plus the R wave amplitude in either V5 or V6 in millimeter. Yeah. So you can see here what we mean by S wave. So you remember this is our S wave, right? The S wave is this guy. This is the S wave for V1 here. And then that's our R wave for V5. So you're gonna find the amplitude, right? How tall and how deep is the S? How deep is the S wave? How tall is the R wave? You calculate that in millimeter. So you remember one big box is 5 millimeter, right? Because a small box is 1 millimeter. So one big box is 5 millimeter. So let's say I want to count from here. From that point, we have 1, 2, 3 millimeters. Then we have one big box. 5 plus 3 millimeters, that would be 8. And then we have 1, 2, 3, 4, I think about 4. Yeah, not up to one big box for the second, for the lower part. So that would be 8 plus 4. That's approximately 12, right? That's 12 millimeter, rather, equals 12, rather, not approximately, equals 12. So the S wave amplitude on V1 is 12. Then let's look at the R wave amplitude for V5. So starting from here, so we have 1, 2, 3, 4 millimeters. Then one big box, 4 plus 5 millimeters, that's 9. And then also have another 4, not up to one big box to the tip. Right. So that would be 4, 8 plus 5, right? That would be 13 plus 13 millimeter. So this is what, 25, right? millimeter. The magic number is 45. Magic number is 45. If you had the S wave amplitude with the R wave amplitude, and the amplitude is more than, so S wave amplitude on V1 plus the R wave amplitude on V5, if the amplitude is more than, I think, confirm this, is 35, 35, 35, 35 is the cutoff, yeah. If the amplitude is more than 35, that patient has hypertrophy, ventricular hypertrophy. Yeah, ventricular hypertrophy. So, but if the amplitude is less than the for the 35, then it's normal, right? Yeah, because the thicker the ventricle gets, right, the taller this amplitude will get. Because now I have more myocytes, they're gonna generate more, right? Action potential. So the R wave gets taller on in V5, V6, the S wave gets deeper, right? In V1. Yeah. So if it's less than 35, normal, more than 35, hypertrophy. So that's that. For cardiac tamponade, you're looking for what we call electrical alternance, right? Suspect venous cardiac tamponade. So they're gonna give you somebody that has, it could be maybe after trauma, post MI, whatever. Patient is hypotensive, muffled heart sound, the JVD is there. So you're thinking, oh, this looks like tamponade. If you want to confirm your ECG, look for electrical alternance, right? So alternating amplitude, bit by bit, alternating amplitude, right, of the R wave of QRS complex. So the R will be taller, shorter, tall, short, tall, short, because with each beat the heart is basically moving around, right? The heart is moving around in the pool of blood or fluid. Yeah, so you're gonna see this is what called electrical alternance. So there will be bit by bit alteration of the height or amplitude, right, of the QRS complex or the R wave. So once you see this electrical alternance, cardiac tamponade, pick your answer. You may also see that the total height of the wave will be short. So instead of having R waves that are as tall as, you can see, as tall as like 30 millimeters here, which is, this is the normal height, it may be just this tall. Because the fluid surrounding the heart will decrease the conduction of the amplitude as well. So you're gonna see overall the amplitude will be short, then you're still gonna see this bit by bit alternation, right? Yeah, alternating tall and short, right, amplitude. So that will definitely be electrical alternance. That'll be cardiac tamponade for sure. Yes. So with those, they can test, right, for ECG. But let the vignette guide you as to what the condition is, and then just look for the specific finding you're looking for, and then pick your answer and move on. Yeah, that's it. Let's transition to arrhythmias. Arrhythmias, abnormal heart rhythm, right? How will you approach ECG for arrhythmias? So we're gonna do three things. So I want you guys to write down this step, right? If you suspect the venous arrhythmia and you want to read the ECG quickly, number one, start with the rate. Determine the heart rate first. Approach to ECG for abnormal reading arrhythmias. Number one, read the rate. Determine the rate. If you're not giving like the pulse, right? Not giving the patient's pulse, so you need to determine the pulse rate or the heart rate, right? On ECG. Determine the rate. How do you determine the rate? Quickly, pick two adjacent waves. So I can pick R and R wave, two adjacent R waves, or you can pick two T waves, either one, TT, or you can pick two PP. But remember that what the QRS complex and the T wave tells you about the ventricular rate, while the P wave tells me about what atrial rate. Because sometimes they will not be the same. In a normal heart, they should be the same rate, right? Because the AV node connects the atrial and the ventricle, and they are both paced by the SA node, the master pacemaker. But in certain disorders, we're going to see like some heart blocks. We're going to see like AV dissociation, right? Where the ventricular rate is different from the atrial rate. So, but you can quickly check both of them, right? Just to make sure. Yeah, you can check the PP rate and check the P wave rate, check the R wave rate quickly to make sure they are the same. So you know that what, yeah. the ventricle is not disconnected from the atria, and vice versa. So what you can do is what? So once you determine your two adjacent waves you want to use, so let's use this RR here. What you're gonna do is what? Count the number of big boxes between them quickly. Count. So this is my R wave. This is the second R wave. We count the number of big boxes between them. 1, 2, 3 in this case, and then you take 300. 300 is a constant. This 300 does not change. 300, your formula for this will be 300 divided by what? The number of big boxes between adjacent identical waves. So in this case, we're using adjacent R waves. The number of big boxes between them was 3. So you take 300 and divide that by 3. Divide 300 by 3, and you're going to get 100. So this quickly gives me, right, the approximate heart rate for this patient as what? 100 beats per minute, which is like the upper limit of normal in this case. So 300 divided, that what you need to remember will be 300 divided by the number of big boxes between two waves, two adjacent waves. Yeah, so that 300 is a constant. So all you need to do, you look at ECG, quickly identify two adjacent waves, RR, PP, whatever you want to use, count the number of big boxes between them, divide 300 by that number, that will give you the approximate rate for that patient. If I do it for the P, right, it's going to give me the same thing. This is the P here, this is another P here, yeah, and you can count. So there's a 1, 2, 3, 4, 5, like the first big box, 1, 2, 3, 4, 5, second big box, 1, 2, 3, 4, 5, thereabout, right? About 3 big boxes as well. So same as the RR interval. So the atrial rate is about 100 beats per minute. So they are paced by the same pacemaker. Yeah, so it's a good thing. The atria is connected to the ventricle. They are not disconnected. So these are you quickly determine rates. That's your first step. Second step is determine the rhythm. So we know the rate. Next thing, check the rhythm. Two things about rhythm you're looking for. You want to determine if the rhythm is sinus. You want to know if it's a sinus rhythm or non-sinus rhythm. Second, is the rhythm regular or irregular? That's what we're looking for, the rhythm. So first, the rate. Second, determine the rhythm, RR. Rhythm, under the rhythm, two things. Is it sinus rhythm or not? Second, is it regular or irregular? How will you know? How will you determine if it's sinus or not? You'll identify. So I remember what we're using here is the word. Always, if you're doing with arrhythmias, use your rhythm strip. You can see, right? The rhythm strip is the longest strip at the bottom of the ECG. Don't look at 1, 2, 3, blah, blah, blah. All those ones are going to be good for MI and whatnot, right? All those ones I've talked about before, like MI and infarction. So you want to read everything quickly. But when it comes to arrhythmias, just go to the bottom of the ECG, the longest strip that you have there, which is the 2 here that we have in this example. Strip 2, you can see is the longest one. It's not broken or segmented. So this is what you want to use for your arrhythmias. So just go to the bottom and use that one. Forget the rest and focus on the last one at the bottom, the longest one at the bottom. All right. So what I'm going to do here is to determine your reading, the sinus reading, right, or not. Identify your waves. Identify all your waves. So make sure that all the P waves are followed by KRS complex. Make sure that all the P waves followed by KRS complex followed by T wave. P, KRS, T. P, KRS, T. And if I quickly look across the strip, you're going to see that what every P is followed by KRS and every KRS is followed by what? T. Every P is followed by KRS and every KRS is followed by T. Every P, KRS, T. Right, so this is a sinus reading. It tells me that the reading that is pacing the heart, right, is originating from what? SA node. This is telling me that the reading pacing the heart originates from the SA node. So that's why the atria gets depolarized first, then the ventricle gets depolarized second, KRS, and then ventricular repolarization, T wave will follow. And then atria gets depolarized next again, first P, KRS, T. So it is sinus reading. It's coming from the SA node. If the reading, we're going to say examples of conditions where the reading doesn't look like this. If you look at the strip and some P waves do not have KRS complex, or some KRS complex don't have T wave, or some KRS complex are not preceded by P wave, or they are the P wave comes after the KRS complex, then you know this is a non-sinus reading. It's not sinus. Something else is spacing the heart, not the SA node. Yeah, so it's abnormal. But if you see this reading, it's sinus reading. SA node is the one pacing the heart. Okay. Now, next thing, determine regularity. Is it regular or irregular? So basically, you want to look at the distance between what? Between the adjacent waves, right? So I want to see if the distance between RR intervals are the same, distance between PP intervals are the same. So quickly, you can quickly estimate this, right? Or you can count the boxes between them and see, right? If they have equal number of boxes between the RR intervals, or just by looking at them from experience, you can tell that, okay, these are all evenly spaced. You know it's a regular reading. If the waves are unevenly spaced, then is what? It is irregular reading. So like in this patient, right? So far, what do I have? I want to report this ECG to you. So far, this is what a patient with what whatever patient is a patient HR has a rate of what about 100 beats per minute. The rhythm is sinus rhythm because all the P waves have KRS complex, all KRS complex have T waves, it is and so on. And then it is what it is regular as well because the waves are evenly spaced out or evenly spaced. So it's sinus rhythm. That's your second step reading. Third step is what? Look at the waves more closely, right? So the third step, you want to look at the waves more closely, look at your intervals more closely, look at your segments more closely, and make sure what they are normal. Remember, we have normal range. So I look at my waves more closely. I see the P wave. So the P wave looks normal, just like it should look. It shouldn't be too big. Shouldn't be double P wave. It's just a single right wave. And then I will quickly estimate my PR interval and make sure it's actually normal. So you can see this is within one small box or less. So that is okay. It's not prolonged. Nothing's wrong with the AB node. Or there's no AB node block, or there's no. And if it's absent or not there or too short, then you know there's an accessory pathway, right? Bypassing the AB node. So patient, this is normal. Then look at your KRS complex more closely. Make sure the duration is okay, right? And it is okay. It's about two small box in this case. So that is normal. It's less than 3. Narrow, okay. The ventricles are depressed. Normally, nothing wrong with the Purkinje fibers. No heart, no bundle branch block, things like that. Right, that's good. And also, you can look at the amplitude as well, and you can see this is pretty good. They're not too tall. Yeah, and then you look at your T wave. T wave is there. Also, it's not too tall. If it's as tall as something like this, as tall as R wave, right? You know that's tall T wave. Yeah, so it's not too tall. It's not inverted, going this way. All right, so that's normal. So it looks normal, and then also you now check your QT interval, right? And make sure it's within like 2 big boxes, which is what we have here as well. Yeah, so there's nothing wrong with there's no QT prolongation, right, in this patient. So I look at it much more closely. And then once you see that all those, and look at SC segment 2, right, it's the same level as the PR interval. So there's no elevation or whatever. So I look at them more closely, and once you see that all these are within order, so this patient has a normal ECG, a normal heart, nothing is wrong, you're done. You move on. So that's how you can quickly, 3 steps: rate, second reading, sinus versus sinus, and then regularity. And then third, look at the waves more closely. Look at the P wave shape. Look at the interval, PR interval, duration. Look at the KRS complex shape and their duration. Look at the T wave shape and then look at the QT interval and as well as the ST segments. Yeah, if all those are normal, this is a normal ECG, likely normal heart. Nothing's wrong here. Okay. So that is stepwise approach, right? If you suspect arrhythmia, so you want to do quick comprehensive read, right, of an ECG. So let's look at some pathologies, abnormalities. Let's start with this one. So Ross, let's say I want to read this ECG. What will you read first? What will you determine first here? Okay, so what is the approximate rate here? No, be specific. Be specific. We have to be as precise as possible. Is it five or six? Okay, six. Okay, so what do we do with that number? Okay, that will give us what? 50. So the approximate heart rate in this one is what? 50 beats, right? Per minute. Is that normal? No. So the patient has some bradyarrhythmia. Good. Hence bradycardic. Very good. So if you notice, right? So the as long as the number of big boxes between two adjacent waves is between three to five, right? 3 to 5. That will be a normal heart rate because if I have three big boxes, that will be 100, right? Beats per minute. If I have five big boxes, that will be 60 beats per minute, right? Yeah. So a normal person should have big box between 3 to 5 big boxes, right? Between the waves to be normal heart rate to determine that to classify that as a normal heart rate. So which means if the number of big boxes is above 5, then we deal with a bradycardia. If the number of big boxes is below 3, we're dealing with what? A tachycardia. Make sense? Good? Alright. So patient is bradycardic. What do you do next? Okay. So what do you think? Is the rhythm sinus or not? Thank you very much. PQRST, 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 PQRST. Alright. So rhythm, sinus rhythm. Is it regular or irregular? Mhm. Okay. Okay. All right. So sinus rhythm and it's regular. All right. So 50 heart rate, sinus rhythm, regular. And let's look more closely now. Tell me about the P wave shape, KRS shape, the T wave shape. Then tell us about the intervals as well, if you think they are all within normal range. Yeah, but they still all look the same, right? Remember, any change you're giving will be very, very prominent. So even if it's subtle, just see it as normal variation. Yeah. Okay, what about the PR interval? Is it normal? Normal distance. PR interval, is it normal? Right now, right? It should be within one big box, right? Yeah, and we have that here. Okay, so normal PR interval. Okay, what about the carriage complex width? It is narrow. It should be narrow. This is normal. This narrow carriage. Well, it should be less than three small boxes, right? Yeah, narrow carriage complex. So this is normal. It should not be wide. If it's wide, that's where the problem is. Too long. Duration is too wide. Problem. It's narrow. That's good. What about the T wave? Okay, T wave is okay. I mean, generally, I just usually, if I want to know if T wave is tall or not, you can just compare it with what? P wave, right? If somebody has P wave, so T wave should be about maybe twice, right? approximately twice of P wave. Can you see that? Yeah. If it's way taller, then you are dealing with peaked, right? Peaked T wave. Yeah. So but this is pretty good. And then what about the QT interval? Okay, it's more than two boxes. But here, are we concerned? Not really, because remember the heart rate is slow. Patient is beating at 50 beats per minute, right? So there's something, if a patient has bradycardia and the QT interval is prolonged, maybe by 2 millimeters or something like that, it's not a cause for concern because QT interval will get longer with increased heart rate and it's gonna get shorter normally, right? With faster heart rate. Yeah. So I'm gonna be more concerned if there's prolonged QT interval in somebody with normal heart rate. Makes sense. But if a patient is bradycardic and they have prolonged QT interval, usually I think there's a way you can check corrected QT interval, but don't worry about that. Just use your judgment. Heart rate is low, QT interval is prolonged by maybe like 2 millimeters. Not that massive, not up to like one box, additional box longer. It's likely just a normal, right? Very because of the bradycardia. And if yeah, so I'm not gonna worry about that. So this is gonna be normal. So this patient so far summary patient is bradycardic, right? Heart rate is low, less than sorry, heart rate is above 50. Patient has sinus rhythm that is regular. So your diagnosis there will be what? This is sinus bradycardia. The heart is beating slowly because of what the SA node is slow. The heart is beating slowly because the SA node itself is slow. So this may have some pathology affecting the SA node. It may be infarction of the SA node. It may be taking beta blockers, calcium channel blockers. Yeah, taking muscarinic agonist. Yeah, so vagal, increasing vagal tone, right? All those things can slow down the artery. So, but this is sinus breaker. Or this might be an athlete. Now, the athletes have a lower resting heart rate. Yeah. So, yeah, but this is a sinus bradycardia. The heart is beating slowly because the SA node, the pacemaker itself, is beating slowly for some reason. Yeah. So good job there with the approach. All right, let's see another one here. All right, Entasha, try this. Okay, 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 okay. So sinus, is this regular or irregular? Regular. Okay, regular sinus rhythm. Very good. All right, let's look at the waves more closely. Very good. Good. So increased PR interval. So what does that tell me pathology wise? Heart block. Where's the block? AV node. What type of heart block is this? Type. Well, we have only prolonged PR interval. First degree, right? So with the first degree, right? Because yeah, this is the initial. Once the AV node is blocked, the first change you're gonna see, right? Right, it's gonna be prolonged PR interval. That's it. Otherwise, everything else, because you can see everything else is normal. Heart rate is normal, right? Rhythm normal, sinus normal, right? But the only thing is the other prolonged PR interval. That's it. So that will be this early initial change. So it's still like first degree. The block is not that bad yet. First degree block. Make sense? Good. Okay. And this patient management wise, we just observe because first degree blocks are benign. They usually have normal heart rate, they're going to be asymptomatic. You just observe them, you don't have to do anything. And they rarely progress to worsening blocks. So, yeah, we just observe and yeah, that's it. Oh, we're going to get there. This first degree progressing slow and steady. Right. All right. So that's first done. Okay. Shanine, floor is yours. Mm-hmm. Right. So, but if you notice here, right, heart rate varies. Can you see that it varies? So, the Samara interval, like you said, 8 boxes. This one has what 4 boxes, right, within normal, and then this one will have a longer, right, distance. 11, right. So the rate here, you can say it varies, maybe between, like you mentioned, up to maybe 20 beats per minute to about maybe 100, right, beats per minute. But definitely, since I have a bradycardia, this is definitely something, right? So a lot of bradyarrhythmia, right, in this patient. Make sense? Yeah. So because I have more waves that have these longer durations, so it's my case varies between that. Okay. All right. So rate varies between that, and remember this is ventricular rate. This is purely ventricular rate. If I want to determine atrial rate, I can use the P wave, right? To determine atrial rate, and those are still 1, 2, 3, 4. That's still within normal range, yeah. But ventricular rate is definitely varies. Remember, when you palpate somebody's pulse, you're actually palpating the ventricular rate. But it's the ventricle that pumps blood into the aorta. So the pulse rate is actually ventricular rate, not atrial rate. Okay, so rate varies between bradycardia and normal heart rate. Okay, so what do you do next? Okay, determine reading. So what do you think about the reading? Like inverted, right? And downwards. So that's fine. Then this is another P, right? Is there carriage here after this second P? No carriage, no T. Then we have P, KRS, T.
P KRST, right? Then we have P without KRST, P without KRST, right? So this is a non-sinus reading. Good. And it's irregular. Thank you very much. Good. Non-sinus irregular. All right. Then let's look at let's take a closer look. Is there another abnormality on closer look? Right, there are P waves that like QRS complex. So we can say that what the P wave to QRS complex ratio, actually if we're looking, let's take this segment here. P wave to QRS complex ratio is about maybe 1, 2, 3, 4, about 4 or 3 to 1. So we have about 1, 2, 3 P waves, but only one QRS complex, only one of them has QRS complex. Right. And even look at this one too, about 2 to 1 ratio in some locations. So definitely there are P waves without QRS complex. So what do you think? What is going on? Why will I see P wave but there's no QRS complex following the P waves? Where's the pathology? It's also AV node block. Good. AV node. So AV node cannot conduct, right? Some of the action potential to the ventricle. So this AV block as well. But what type of AV block is this? No, we just saw type 1. Sorry, second degree, okay. Second degree, right? Is it type 1 or 2? Yeah, P. So remember, okay, so first of all, type 1 is milder, right? Type 2 is worse, correct? So in which one will you see more P waves without Caris complex? Type 1 or 2? More P waves without Caris complex. Right. This has to be type 2. This looks bad. It looks worse because I have a lot of P waves here, right? More P waves without Caris complex than P waves with Caris complex. Can you see that on this ECG? Yeah. There's a lot more. There's a 1, 2, 3, 4. At least 4 P waves without Caris complex, and I have 1, 2, 3, 4, right about 5 also. But definitely you're gonna see a lot of P waves here without Caris complex. So there's like more P waves without Caris complex. If you look at the set, yeah, of waves following each other. And then this one too has what? There is normal PR interval. Look at the PR interval here. It's normal, fixed and normal. It doesn't change. But in type 1, there will be progressive prolongation, right, of the PR interval before you see a drop bit. But in second degree type 2, two differences. First of all, I'm going to have more P waves without QRS complex in type 2 second degree than I'm going to see in type 1 second degree. And then the PR interval is normal here. PR interval is normal and fixed, it doesn't change in type 2 second degree. Type 1 second degree, prolonged PR interval for before you see the drop it. Two things, no, two things. This one, yes, yes, type 2 doesn't. And since type 2 is also worse than type 1, there will be more P waves here without Chiara's complex. Yeah, than type 1.
So this is type 2 second degree, which is the one called either Mobit 2 or just Mobit as well. This will be type, this second degree type 1, the one below it, this will be type 1 second degree. Then type 1 second degree, although this one too, the rate here, if you want to estimate 1, 2, 3, 4, 5, 6, 7, so this is definitely bradycardic as well. Rate is less than 60. Then if I check the patient um, rhythm is non-sinus. So because here I have PQRST, PRST, PRST, and I have a P wave without QRS complex, PRST. So it is not a sinus rhythm because I have some P waves without QRS complex, non-sinus, and then rhythm, it looks regular. Sorry, irregular. The distance is longer than the distance here, so a little bit irregular. And if not look closely, so once you see that okay, some P waves are not following. So if I want to find the ratio here, P QRS ratio, look at what I'm saying here. So let's say we take this group here from this here to the P wave that does not have QRS complex, right? To this point. How many P waves do we have with QRS complex? How many P waves total is there? 1, 2, 3, 4. So 4 and then 1, 2, 3 Keras complex. So you can see the ratio, the P to Keras complex ratio for this one is 4 to 3. Unlike what we saw in the first degree, in the second degree, which is worse, we have what the ratio there is actually what is like 4 to 1, 3 to 1, 2 to 1, because you're gonna have like a group like this. So if I start here, something like this, where you have 1, 2, 3 P waves, but only one Keras complex. Right. So like 4 to 1, 5 to 1 ratio, because there'll be more P waves without Keras complex, right, in the second, in this type 2, second degree type 2. But in second degree type 1, there will be just a few P waves without Keras complex. So the ratio is usually like 4 to 3, right? 4 to 3, 3 to 2, 5 to 4, things like that. Then another difference between them is what is the PR interval. So look at the PR interval here. This one is normal. This is wider. This is wider. So there will be progressive prolongation of the PR interval until there is what? A dropped beat. And if you look at the next set again, normal, wider, widest, and then we have the P wave without QRS complex here. But in type 2, you won't see a change in PR interval, it's going to be normal. But in type 1, second degree, there will be progressive prolongation of PR interval before you see the drop beat. That's the difference in them. Another difference in them. Yeah, this. Shani, Glenn, Ross. Right. Again, Ross, try this. How do you know?
Mm-hmm.
So let's start from here. Which which wave is this? T, right? P. Then you can see there's a small p here, right? Just before the R. There's a small p here. It's almost buried in the R, and then we have T, P. There's another P here that is almost buried in the Chiari complex. See, you can see it clearly here. P, P. Two P's before, right? Chiari complex, right? Then we have T, then we have another two P's again before Chiari complex, right? So is this normal sinus reading? No, non-sinus. Good. Is it regular? Mhm. Each of them. Okay, so regular. And all right, so let's take a closer look. What do we see on closer look? Mhm. Not delta. Delta is different. Delta is when the although here it's not delta because look at this one more clearly. There's definitely a PR interval, right? Between the P and the R. Yeah, in delta wave there will be no PR interval at all. So the wave just continues, right? After P waves, right? But if two P waves occur in succession closely together, and then sometimes you might see P wave buried within R interval and or buried just after R interval or buried within it. If you see that, right, they are pacing at different rates. There's no coordination here. That's why it looks like this. So how will I confirm? Calculate the PR. What is the rate for the P waves? What will be the rate for the P wave? We know the rate for the RR is you already mentioned that is what for the RR we have seven boxes between them, right? 2, 3, 4, 5, 6, 7. So that is 300 divided by 7. So definitely less than 50 beats. What is the rate for the P? 1, 2, 3. Big boxes thereabout, right? Maybe 3 to 4 big boxes. So for the R waves, less than 40, 50. For the P wave is what? Right, it's about 100 beats per minute. Why would the ventricle and the atrium be pacing at completely different rates? And they are both coordinated, right? They are both regular, and but they are pacing at different rates. What would, so this patient has what? Right, this is a third degree block. There's complete block. They are completely separated from each other. So the ventricle is pacing at a different rate by a different pacemaker. The atria is pacing at the rate of the ST node. It's being paced by the ST node. Yeah, this is a complete heart block. Once you see different pacing, right? Yeah, complete heart block. Yeah, so third degree. In complete heart block and second degree type 2, this patient require what pacemakers, right? You're going to require pacemakers, but this can lead to death. Yeah, the heart will be beating so slow, the ventricle will be beating so slowly, right? And that can lead to shock and death. So this patient usually require a pacemaker for sure. All right. So those are the like most of them are those are the bradycardias, right? Sinus bradycardia, the heart blocks. Those are the ones that can typically cause bradycardias and that you need to recognize. Then on the other end of the arrhythmias will be what tachyarrhythmias, right? Those actually increase the heart rate, increase heart rate. How do you approach tachyarrhythmias? The approach is slightly different for these guys. Slightly different. So first step is also going to be rate for sure. Start with the rate. Make sure if the rate is high. So if I check the rate and the rate is high, more than 100, or is always a tachyarrhythmia, the next thing you're gonna do is gonna be check the KRS complex. So the approach for tachyarrhythmia is a little bit different. Determine your, of course, you want to start your rate as well to make sure it's definitely tachyarrhythmia. Or patient comes, they have palpitations, racing hearts, they give you the pulses about 144, 150, 200. You know, okay, this is a tachyarrhythmia. So you can check your rate again to confirm, but you don't need to do that. Just move to the next step. Check the KRS complex on the ECG. Right, find the longest strip. Look at the KRS complex. You're looking at KRS complex duration, the width of the KRS complex. Remember, our normal width is what? Less than 3 small boxes. So if I check the KRS complex and it is 3A, it is normal, narrow, which is normal. We are dealing with a what? It's a narrow complex tachycardia. KRS complex is narrow. We're dealing with a narrow complex tachyarrhythmia, and this is what? This is an SVT. It means the tachyarrhythmia originates from what? From the atria or the AV node. It's above the ventricle. That is why the KRS complex is narrow. If the disease is above the ventricle, so the ventricle is fine, it's normal, so the KRS complex will be normal. The ventricle will be depolarized normally. But right, so it's an SVT, it's something above the ventricle. KRS complex is normal, ventricle is normal, you're dealing with an SVT. If arrhythmia is above the ventricle, AV node, or the atria, like AFib, A-flutter, things like that. So once you know, right, that it is SVT, right, the next step for SVT is you're gonna check the rhythm now. Now this is where I'm gonna check the rhythm. You're not gonna check the rhythm and find the P wave. Once you know, so patient has a tachyarrhythmia, KRS complex is check the KRS complex first for tachyarrhythmias. If it's narrow, you're thinking, okay, ventricle is fine. KRS complex represents ventricular depolarization. So if it's narrow, normal size, ventricle is fine, the pathology is above the ventricle, it's an SVT. Then next thing for SVT, check the rhythm and the P wave and find the P wave. Check the rhythm and try to find the P wave. So if I check the rhythm, I'm going to give about 4 scenarios. Rhythm is normal. Normal rhythm and no P wave. Normal rhythm, no P wave. We are dealing with what? AVNRT. Atrioventricular nodal reentrant tachycardia. The tachyarrhythmia is where originates in the AV node. And it's going to depolarize. If I have a tachyarrhythmia, if I have an abnormal rhythm coming from the AV node, it's gonna depolarize the atria and ventricle simultaneously at the same time. But remember, the ventricle is bigger. It's bigger, right? So you're gonna see the KRS complex, and the P wave will be buried within the KRS complex. Or sometimes you might see it as a retrograde P wave, right? Right. So sometimes no P wave, but you can see a retrograde inverted P wave maybe after the KRS complex or just before the KRS complex, but that would be an AVNRT. It's an arrhythmia in the AV node that would depolarize the ventricle and the atria simultaneously. So the P wave will be buried in the KRS complex. You won't see it at all. You're just going to see the KRS, narrow KRS, T wave, KRS T, regular reading or normal reading is going to be what? AVNRT. Right. If you don't see, if it's a regular reading, and you see sawtooth P wave, I'm going to show you pictures, don't worry. Sawtooth P wave. So I see the P waves, but it looks like the tooth of a saw. Multiple P waves that follow each other and they look like this, tooth of a saw, right? That would be what? A flutter. And a flutter can be regular or irregular, so I don't really care so much about reading for flutter, but once you see that sawtooth P wave, just go and pick flutter, whether it's regular or irregular. Sometimes it might be irregular if there's a heart block as well. Yeah, but sawtooth P wave, a flutter. If it's irregular reading, and I see what? No P wave, right? You can see irregular rhythm, no P wave. And you have this erratic baseline. So the baseline looks abnormal. Erratic baseline, no identifiable P wave. That would be what? A fib. Irregular rhythm, no P wave, erratic baseline, A fib. If it's irregular rhythm and you see more than or equal to 3 different P waves, right? Yeah. So it's regular rhythm, but you see P waves, right? There are P waves there, but the P waves look different. They have different shape, different morphology. At least 3 different P waves morphology. They look different, which means each P wave is coming from a different location. This patient has multiple pacemakers, right? In the atria. That we call them multifocal atrial tachycardia, MAT. Multifocal atrial tachycardia. So there are multiple focus of pacing in the atria. So that is why, and each of them will have different shapes of P wave. Yeah, or will cause a different shape of P wave. So irregular reading, but I can see P wave. There will be P wave before KRS complex. You're gonna see T, P KRS T, P KRS T, but it's irregular. But then you're gonna see all the P waves look different, morphologically different, which means they are coming from different locations in the atria. Then that's a multifocal atrial tachycardia. Quick recap. Patient comes in, oh, I feel like my heart is racing, right? In your mind, you think, oh, this is a palpitation of tachyarrhythmia vignette. Or they give you the heart rate is 140, 155, 160. Patient, the examiner can also tell you the pulse is regular, irregular, right? So you think, oh, this is a tachyarrhythmia. Next thing, when you go to your ECG, just look for the KRS complex. That's the next thing you're going to look for. So different approach for this one completely, right? From what we need for bradycardias. So KRS complex is narrow. You know the ventricle. KRS complex represents what? Ventricular depolarization. So that tells me the ventricle is fine. The problem is above the ventricle, is an SVT, either in the AV node or in the atria. Next thing you look for the rhythm and the P wave. If the rhythm is normal, regular rhythm, but you can't find the P wave is buried in the KRS complex or it's retrograde just after the KRS complex, you're dealing with AVNRT, abnormal rhythm in the AV node. And remember, since the AV node is between the atria and the ventricle, if something originates in the AV node, it's going to depolarize the atria and the ventricle simultaneously. So the P wave, since the KRS complex is going to be bigger than the P wave, right? Ventricles are bigger, they are thicker than the atria. The P wave will be buried. It's going to be buried in the KRS complex, or sometimes just comes after the KRS complex, and it's going to be retrograde, right? Inverted. Then you're dealing with an AVNRT. You know the problem is in the AV node. So there's simultaneous depression of the AV, atria, and ventricle in that case, AVNRT. If the reading, regardless of the reading, whether regular or irregular, if I see sawtooth P wave, it's going to be what? A flutter. Sawtooth P wave, A flutter. If I see irregular reading, no P wave, erratic baseline, A fib. So AVNRT is regular, no P wave. A fib is irregular, no P wave, A fib. Then irregular, but I can see P wave, PKRST, PKRST. But the P waves, you see more than 3 different types, shape of P waves. That's multifocal atrial tachycardia. For basic science, we want to know the origin, right? So we want to know the origin of the arrhythmia. Like we said, for AVNRT, origin is what? Location is AV node. That's what the examiner will ask you. Where is this arrhythmia originating from? Is AV node. Usually a re-entrant, right? Abnormality, re-entrant arrhythmia. Re-entrant, there's something wrong with the AV node, so there will be this re-entrant circuit in the AV node. For A flutter, the location of the abnormal focus usually what? Around the what's the name of this? Around the valves. Usually in the
What's the around? I think it's around the valve, the tricuspid valve, the AV. It's within the atrium, right atrium usually, right atrium, close to the what to the tricuspid valve, close to the tricuspid valve leaflets and stuff. A flutter. AFib, the location is usually what? The ostia of pulmonary veins. The location of the abnormal focus, right? Abnormal focus will be ostia of the pulmonary veins in the left atrium, typically in the left atrium. That's where it commonly originates from. And then for MAT, multiple atrial tachycardia is going to be multiple location in the atria itself. So within multiple location in the atrial myocyte themselves. The risk factor for MAT is COPD. COPD can trigger MAT for some reason. Severe COPD is a risk factor for MAT. We know AFib, the risk factor will be left atrial dilation and hypertrophy. I think that also applies for A flutter as well. Right atrial hypertrophy and dilation. Yeah. ABNRT just reentrant circuits in the AV node, maybe from ischemia or fibrosis or something like that. Yeah. But this is what the examiner want to test at this level, like the location of the focus and maybe risk factors as well. Yeah, for those abnormalities. So that's 3A, right? 3B. The what? Mhm. Yeah, that's the name, right? Multifocal atrial tachycardia. Multifocal, multiple locations in the atria. Any other question? Okay. So from their name, the names tell you what they mean, right? You can predict what it means from the names. Yeah, don't like AVNRT, right? Yeah, the name AV node reentrant. Yeah, and atrial dilation. Yeah, hypertrophy. So that's why you can see it in conditions like mitral stenosis, right? Mitral stenosis can cause AV because stenosis will dilate the atria. So 3B is when the complex is wide. Caries complex is wide, then you're dealing with ventricular tachycardia, right? Which makes sense. If the complex is wide, the problem is in the ventricle. Caries complex is wide, something's wrong with the ventricle itself, something with ventricular tachycardia. Yeah, in that case. So this is how you approach, right? Tachyarrhythmias. Caries complex first, narrow SVT, look at the reading of the P wave, that will tell you what type, right? Patient has, and then caries complex is wide, we're dealing with PT, and yeah, you can ventricular tachycardia. The problem is in the ventricle. The focus, the origin of the arrhythmia is in the ventricle, ventricular myocyte, and the mechanism for VT is also the same as AVNRT, right? It's usually re-entrant. They have this re-entrant circuit. Yeah, something that is going in circle, right? So there's abnormal tissue. So you're gonna see this. The tissue there, it's abnormal in such a way that action potential there cannot dissipate, it cannot leave. So it's going to stay there in the circuit and keep going in circle like this. And then they're going to be discharging, right, outwards and be depolarizing the ventricles simultaneously. Yeah.
and the ventricle will be beating at a very, very fast rate. But since the problem is in the ventricle itself, the ventricle will not depolarize normally. So the depolarization takes time. It's going to be wider. We're going to see wide carriers complex, but it's also a reentrant circuit. Risk factors for VT will be what? Ischemia. Patient with cardiac ischemia, right? Ischemia is the major risk factor for VT. Ischemia, as well as electrolyte abnormalities like hypokalemia, hypomagnesemia, things like that. Yes, they can cause VT. But the most number one risk factor will be ischemia. Patient with MI and stuff. Re-entry, trans-circuit, same mechanism. All right, we're gonna stop here. We're gonna potassium, magnesium, calcium abnormalities. Typically hypocalcemia, hypokalemia, hypo, even hyperkalemia as well. Hypomagnesemia, low magnesium, low potassium, high potassium, low calcium. Yeah, high and low potassium. Right. So we're gonna stop here. On Monday, we're gonna look at examples of these ECGs for these tachyarrhythmias, and then we move on to the next thing. Any questions? So practice, right? Take home assignments over the weekend. You should practice. So and you can practice with, thank God for Google, right? Internet. Go to the go to Google and you can type in some of the all the ECGs we looked at today, or examples of pathology we looked at today. Type them all in Google and then go to the images, right? And just look at examples of look at unlabeled ECG first, the ECG that are not labeled, and you try to read them yourself and see if you can use the approach that we just established, right, to make a decision to recognize the ECG for each of them, and then you can now look at maybe a labeled ECG to confirm, but you should be able to get through, right, with this approach that we just established today. So you practice all of them from the MIs and the right cardiac tamponade etc. Look at examples of the hypertrophy, all of them that I mentioned, bradycarditis, yeah, and then look at the brady arrhythmias, sinus bradycardia, blocks, body blocks, and then look at ECGs for the tachyarrhythmias as well using this approach. KRS complex, the reading, P wave and go, and then see if you can get through. Once you're gonna see that, yeah, you should be more confident, right, before Monday. And on Monday we look at examples of this together, and I'm gonna bring probably some other random messages to write that we can practice with, and then we'll move on to the next thing from there. All right, guys, I will see you later. Have a wonderful weekend again. Yeah, bye. Bye.